Good evening, everyone. Welcome to this webinar by ESU. We have a star-studded cast today to talk about some very important aspects of TURBT and possibly not doing TURBT in the setting of muscle-invasive bladder cancer. So myself, I'm in Edinburgh, and my colleague and co-chair, Professor Gontero, is in Turin. We have speakers, and I'll just introduce them very quickly. Professor Nick James is in London. He's an oncologist. Professor Alexandra Messon-Lecomte is in Paris, as is Professor Morgan Rupre. Please ask questions in the discussion section of your chat box. We'll be having a look at them live, and we'll try to answer them as we go through the talks, and also perhaps have another live discussion towards the end. So if Professor Gontero does not have anything else to add, we'll move on to the first speaker, who's Professor Nick James, who's going to talk to us about the fact that TURBT is obsolete in the context of bladder sparing approach in muscle-invasive bladder cancer. Over to you, Nick.
So, yeah, I'm not really quite as radical as Param just said, but I'm going to just run through the thing. So it's been an interest of mine for quite a long time about how we diagnose bladder cancer. So, and the answer is we currently do it the same way that we've done for pretty nigh on a century now. It's very unusual for a procedure to be so unchanged in such a long period of time. You can see the instrument described by Terence Millen is pretty similar to the instrument that you guys are using. I know you'll say yours are better, but it's fundamentally the same. And it's a very curious pathway because you're using a rigid instrument to make a whole load of, or input into a whole load of really quite complicated decisions. And so it's worth splitting it down into what you're doing when you do a TURBT. So it's giving you a pathological diagnosis, yes. If it's non-invasive, it'll give you, if the tumor is non-invasive, it'll give you accurate staging, and simultaneously it's the treatment, you've taken the thing out. And of course, if you take the thing out, you're also palliating symptoms like hematuria and so on. But once we move to muscle invasive, which is 20% of the total, so it's not like a small amount, yes, you're still getting a pathological diagnosis, except that you often get it wrong because you sample quite frequently. Now, I know done properly you won't, but often because of the numbers of hematuria cases you have coming through, it's hard to make sure the right person is doing the right resections, and it's happening in lots of different hospitals, and there's a lot of variability in practice. For the same reason, it'll give you inaccurate staging, particularly if you undersample muscle. You won't get the diagnosis right, and you'll have to go back in, and that's adding a delay. It's most definitely not the treatment, because you're always going to do something else pretty much. You're either going to do a cystectomy or chemotherapy or radiotherapy or palliative care indeed, but it's not, in general, a very good way of palliating cancer to cut half of it out. You either want to cut all of it out or treat all of it with something else like chemotherapy or radiotherapy. So you can hypothesize you can do a better pathway. So for non-muscle invasive bladder cancer, if you can identify on your initial staging, imaging and biopsy, you can then fast track those to TURBT, and depending on the extent of the tumor, you can stratify who does it, because you want the more senior urologist doing the bigger, more challenging, nasty non-invasives, because it really matters that you get those right. Whereas the smaller TA type tumors, arguably you don't need such a senior person to get a good result. For muscle invasive cancer, we generally do not treat cancers by debulking them. We generally biopsy them, stage them with imaging, and then decide what we want to do. Now, in the trial I'm going to show you the data from, most of the patients, but not all of them, then went on to get some sort of TURBT in order to decide on the fine detail of your treatment. So most patients, I will argue, do not need debulking, and that includes for bladder preservation. But you still will want to know about CIS, you'll want to know about, you may want to stop bleeding, you may want to be sure that you've got muscle invasion, things like that. But the key thing is, once you've done the imaging and staging, you know they're muscle invasive, you know these people need treatment quickly, and you know they need input from the senior people. You can fast track them to the right place. But you do need to separate people. So there's a number of stages in the pathway. First is histology. You don't need grams and grams of tissue to do histology. We're very happy with tiny little needle cores for the prostate. You can get tissue out from even a limited flexible cystoscopy. But even if you can't do that, you don't need to do a full debulking to get histology. The more you debulk, the more you run the risk of perforation, the more you run the risk of a longer stay in hospital and so on. And for most cancer diagnosis, we don't debulk, we biopsy. Do you need it for variant histology? Well, it's just not very good at that. And just to show you some data, this is a comparison of histology at TURBT. This is from a cystectomy series from Canada, published about 4 years ago, compared to histology at cystectomy. And you'll see for patients staged as pure urothelial cancer, actually 20% had squamous differentiation. If you're looking at the major variants, patients staged as pure squamous, actually a third of them were actually urothelial with squamous differentiation, which matters a lot because we tend to say that squamous carcinomas are different in terms of how you should treat them. For pure adenos, a small number of the total, but actually it turns out that a quarter of them were urothelial after all. So you're getting it wrong a third, a quarter of the time when you're calling a variant. If, on the other hand, you say you want to split it up into the molecular consensus ones, luminal, basal, and stromal, neuroendocrine, and so on, you need hardly any tumor for that. You can do it on a single paraffin embedded slice. This is from the consensus molecular classification paper, showing you separate patients very convincingly on very small amounts of tissue. You don't need to debulk to do that either. And this is research from my own group. You can do targeted sequencing of bladder cancers from 50 mils of urine. And this just shows that for a whole range of mutations with either the urine pellet or the urine, you get accurate calling of the mutations on really very small amounts of material, 50 mils of urine. And it's prognostic. I'm not going to wade you through this now. So do we need it for staging? So as a staging test, it's very, very inaccurate. A lot of patients staged as non-invasive will turn out to be invasive. And so it's not a really very accurate way of making what are actually very critical decisions for a patient. So again, this is from the same paper I showed you earlier, a very large number of patients, as you can see. This is the TURBT stage, this is the cystectomy stage. This is the data that is so striking. So TA and to T1 and CIS, but for whatever reason going on to a cystectomy, over half of them are actually muscle invasive. CIS only going on to a cystectomy, again, over half of them are actually muscle invasive. And this is obviously less relevant, but it clearly shows that actually you can sometimes, but not always, end up with a complete resection from your TURBT, but mostly you don't. So we have a way of classifying these tumors with VIRADS. It's kind of maps to the PIRADS things. This is using an MRI scan. So we have a worked up classification system for MRI done prior to TURBT. And so what we wanted to test in the bladder path trial was whether we could identify patients with a combination of flexible cystoscopy and plus or minus a biopsy and an MRI scan ahead of anything further. And all patients in the trial went on to get histological confirmation one way or the other, either at the flexi or at a limited TURBT if they're randomized to the MRI half. We randomized patients just coming through the hematuria clinic with a bladder mass, and we asked the urologist to split into probable non-muscle invasive, and those just went straight to TURBT in both arms, or possible muscle invasive, about half of the total. They went on to get an MRI scan in order to separate the non-invasives from the invasives. The primary outcome for the trial was time to definitive treatment, because what we felt was that if you do a more accurate initial assessment, you make all your subsequent decisions better, as has been shown in prostate cancer. And we had an initial feasibility stage, and this is how we split the probable from the possible muscle invasives. And I've gone through this already. So the feasibility data showed that we were able to get patients down the MRI pathway as we intended in a timely fashion. We reported that some while ago. But the key outcome was, what did it do to the time to correct treatment, which was either surgery, radiotherapy, chemotherapy, or palliative care. On the control arm, because of all of the toing and froing that you get between resections and all the rest of it, the median time was 98 days. And this is typical across the world, not just in the UK. On pathway 2 with the MRI initially, it dropped almost by half to 53 days. So this is a Kaplan-Meier of time to treatment. So we considerably accelerated time to treatment for the muscle invasives. This is published recently in JCO. The secondary outcome was time to treatment for all patients. And as you can see, we had no adverse effect on the non-invasives, who of course make up the bulk of it. And if we look at the non-invasives specifically, non-invasive, this is blue is the control arm, red is the experimental arm, you can see that even though we've added an MRI scan to their management, we're not delaying their time to treatment. They're still getting treatment quickly. So the next thing is it an essential component of treatment? So if you're going to take the whole bladder out and you know they're muscle invasive from the scans, why would you do a TURBT? You're just adding time in theatre, morbidity, and no real benefit. You may want to do a limited pre-op assessment to look for CIS and so on, but you really don't need to debulk it all. But in the bladder preservation setting, there's no randomized data showing you need to do it. But what I will show you is some retrospective data from a trial I ran called BC 2001. And we looked at clinically assessed stage. This is the size of tumor. This is on overall survival. So you can see just measuring the tumor was better than the clinical stage in terms of separation. This is 3 centimeters or smaller. This is either unmeasurable or bigger than 3. We also looked at extent of tumor resection, which is of course prognostic because you can't resect the T3, T4 tumors. But the thing I would draw your attention to, oh, sorry, I'm changing my slides too fast, thank you, is this, which is these patients only had a biopsy. So if it mattered that you debulked, the biopsy patients should do worse than the incompletely resected patients, but you can see they actually do better. They're somewhere sitting between the two. So it's a mix. These biopsy-only patients are a mix of completely and incompletely resected. Residual mass is also prognostic for the same reason. You'll have a residual mass if you've got extravesical extension. So all of these things line up: stage, size of tumor, extent of resection, and so on. But that doesn't mean that you need to resect in order to do radiotherapy. So my interpretation of these data is residual mass equals high stage equals poor prognosis. And that will be poor prognosis whether you do surgery or whether you do radiotherapy. So it's not a test that tells you whether you should be doing bladder preservation or not. And oncologists in the UK do not view it as being a requirement that you have a complete debulking. 2/3 of patients in the UK are managed with bladder preservation, not with surgery. It also therefore doesn't follow the TURBT, or at least a complete TURBT was actually needed. So the conclusion from the bladder path trial was that if we put an MRI scan into the staging, firstly, it's feasible in a multi-center setting. 17 centers recruited to the trial I showed you. Because you've got a more accurate assessment of the disease, you make better decisions. So you can fast track people to the right next stage, which in most cases was still a TURBT, but in 1 in 6 patients, they avoided TURBT completely. So for example, these patients, you do the scan, the patient's got metastatic disease. They don't need a TURBT unless they've got a badly bleeding bladder, for example. They need systemic chemotherapy or they need palliative care. Putting an MRI in initially did not affect the pathway for the non-invasive patient. And we don't need to do a debulking in order to profile the tumors, either in terms of variant histology or in terms of lumen or basal and all these different subclassifications. We can do that on much smaller samples, and probably increasingly we'll be able to do it on urinary DNA as well. So you not necessarily going to need tissue. So I think the image-directed pathway has got a lot of real pluses to it. And we're just discussing workload and access. Now, in our clinic, these patients come through the same pathway in terms of the rapid diagnosis clinic as the prostate patients, all of whom get an MRI scan. And of course, they outnumber the patients with a raised PSA, massively outnumber the patients with a bladder mass on histology, on flexible cystoscopy. So these patients you can pick them out quite easily. Just picking up the question in the box, the criteria we used, we showed a Likert scale. We produced aids for the surgeons in theatre to have a look at, and they were pretty consistent in identifying the definitely non-muscle invasive ones, which are about half of the total. I'm happy to share that afterwards, and it's in our papers. Just like to finish with a little bit about what gets called trimodality therapy because it's a misnomer. So this is the American style of doing things, which includes a maximal TURBT, no CIS, no hydronephrosis. Good bladder function, I would agree with. There's no point in preserving a badly functioning bladder. And often an initial therapy with a look halfway through, which we don't do either. This means you're picking a subset of patients, and they're mostly younger, more fit patients, at least in North American practice. If we look at what happens in the UK, we are doing TURBTs because it's a standard pathway thing, but we don't insist on complete debulking, and we do tolerate CIS as long as it's not too extensive. We will manage hydronephrosis, don't view it as a contraindication, and we give a single block of treatment, and patients where it doesn't work get a salvage cystectomy, which is around 10 to 15% will end up with a salvage cystectomy, and it's the mainstay of therapy, particularly for older, less fit patients. And this is data from a trial I ran comparing synchronous chemotherapy with radiotherapy alone. I'm not going to go through all of this, but the key message was that you get a big improvement with synchronous chemo. This is just to show you the sort of outcomes. And it's mostly on the invasive recurrences. This is invasive local regional control in the trial, metastasis-free survival, and the cystectomy rate. So you can see the cystectomy rate was quite low. Most patients are keeping their bladder. And my last trial, so this is data from the trial. And if we just superimpose on it, if you look at the blue line, the chemoradiotherapy, this is SEER data from the same time that will appear on top of it. And what you will see is that the chemo-RT line corresponds pretty much exactly with the SEER outcomes for T23 patients, 90% of whom are cystectomy.
Thank you very much. That was amazing. Really enjoyed listening to you. Obviously, I've heard you speak about this many times. We have some questions.
Yeah.
I suppose maybe we can talk about one or two as we have just a bit of time before we go to Alexandra. So this, you did mention the Likert score system, and perhaps just for the audience who may not be familiar with it, could you just explain, please, the criteria for which you use to identify possible MIBC?
Yeah, so what we did, and as I said, I'm happy to share it, is we produced some guides which we sat in the theatre that gave pictures of typical TA tumours, pictures of CIS, things like that, and pictures of typical muscle-invasive tumours. And we asked them to just look at the pictures, and then on a scale of 1 to 5, we asked them to say, do you think this thing is definitely non-muscle invasive, is probably non-muscle invasive, not sure, through to the opposite and definitely muscle invasive. And basically anything from not sure through to probably or muscle invasive went on to get an MRI scan if they were randomized to the experimental pathway. Anyone where they were sure or pretty sure that it was non-muscle invasive just went straight to TURBT. Of those patients, they were about 50% of the total, 98% were non-muscle invasive. Of the patients where they were not sure, about 50% were muscle invasive, 50% were non-muscle invasive, but all the non-muscle invasives were high grade, nasty non-muscle invasive. So the urologists were very good at identifying, splitting tigers from pussycats in essence. And it meant that you halved at a stroke the number of MRIs you did, because there's not much point in doing an MRI scan if you're then going to go and do a TURBT on pretty much all of the patients that are non-invasive. But it meant also with the ones that might be muscle invasive, you've then got what stage they are, whether they're non-invasive or invasive before you start doing your TURBT, and you can tailor the procedure accordingly. Because we're quite happy in our MDT now. If we're happy that the patient is muscle invasive, we're happy whether or not we have muscle in the biopsy to go ahead and do whatever else, cystectomy, radiotherapy, chemotherapy, without going back in and re-resecting. And particularly if you resect all the way down to, to muscle and beyond, you've got a substantial risk of perforation and, prolonged hospital stay and all the stuff that goes with it.
Professor James, well, of course, it has been a fairly provocative lecture, but we knew that in advance, and that was the main reason that we invited you, and we're very grateful that you accepted. I think that we need to explore different avenues, and that's the way that we can move on.
Yeah.
To shifting paradigms once we have maybe more evidence. I just want to focus on some questions that came through. I interpret one question, which I think is also the question that many may have. In many health systems, placing MRI for diagnosing bladder cancer would actually imply a dramatic delay because our MRI is basically packed by prostate cancer diagnosis, which is of course level 1 evidence at the moment. So we may incur in huge prolonging waiting list unless you say that you would select patients that may need to undergo an MRI because they have suspicion of invasive bladder cancer by doing a flexible cystoscopy first. And then in this case, you would probably drop the number of, you would just send for TURBT those who are likely non-muscle invasive, because there's no question that that's the treatment and of course the diagnostic pathway, which is standard. There was another question. I think maybe you want to clarify, because it was probably not clear to everybody that you anyway get at least a biopsy sample with the flexible cystoscopy. Somebody understood that you actually go straight to trimodal cystectomy just based on flexible cystoscopy and an MRI.
No.
You get a biopsy sample. Okay.
No, we got a biopsy from everybody. So we had to be satisfied that they had, a histological diagnosis of cancer. What we didn't insist on, though, and what we don't insist on in my practice at the Royal Marsden now, is that we have a biopsy with muscle in it. If we're happy, if we've done an MRI, we had 2 such patients last week. They'd been resected. There was no muscle in the specimen, but you could very clearly see on both patients' MRI scans that they had tumor going right through the muscle. They were T3 tumors at least, if not T4. We didn't insist on going back in and getting a sample with muscle. We said these patients both need chemo. They're going straight on to chemo. But no, we definitely have tissue on everybody. And also within the trial, 6 out of 7, 6 out of every 7 patients got TURBT as well. But if you talk to the urologists in the trial, which included people like Jim Catto, very well respected bladder cancer specialists, they were saying, well, yeah, we use it, but if we know that somebody is probably muscle invasive, we now will do a more limited TURBT, to assess, operability and so on, but we won't do the full fat, resect everything, because we don't want to delay the actual cystectomy by doing so. And also it means that you can match the complexity of case to the right surgeon if you've done the imaging first. The analogy to prostate cancer, I think, is a very good one here. We're not doing random biopsies anymore. We're sticking the needles in the lesions because you've done the MRI first, and it improves your decision-making with invasive procedures.
These are really important points there, Nick. I think part of it is looking at the pathways and ensuring that these are fast-tracked appropriately. In light of that, I think we should move on to Professor Masson-Lacombe from Paris. Alexandra, over to you.
Yeah, thank you. I'm afraid I'm going to have to disagree with some of what was said. But I'm sure at the end we will find some in the middle position. So my mission here was to defend the TURBT, and I want to be very clear that I'm an MRI user, and that defending the TURBT doesn't mean at all that I do not think that there is some space for MRI in bladder cancer diagnosis, and I will show it to you in the upcoming slides. So those are my conflict of interests. Well, if I had to summarize on the one slide, everything that I'm going to show you on the upcoming 10 to 15 ones is that message that TURBT is unavoidable in most cases. And I'm not going to talk about extreme cases in which you have a huge tumor that is obviously a T4, even by clinical examination or on the MRI, and for whom you don't get muscle on the TURBT because it's too big. I'm going to talk about any patient that has a tumor that might be muscle invasive. And we will look at all the reasons why it's unavoidable. And I'm going to go counterclockwise and finish on the debulking, because I think this is a very important part. So seeing TURBT solely as a diagnostic procedure is highly reductive. And as urologists, we know that bladder cancer goes with some bleeding and some different kind of symptoms. And one of the reasons why TURBT is unavoidable is because it allows management of symptoms. The patient having hematuria, the TURBT is going to solve that in most situations. It's going to allow examination under general anesthesia, which as a surgeon, I consider very important. There are some patients for whom I will say at the end of the examination that the cystectomy is not feasible, while on the contrary, some patients might have a big tumor, but on their general anesthesia examination, I'm going to say, well, it's completely feasible. So this is an important part. Let's not forget the clinical part. It's going to allow prostatic urethra biopsies, which also as a surgeon might be very important in deciding the kind of urinary replacement you're going to do. It's not only about going to chemotherapy and cystectomy, it's also about doing what kind of urinary diversion you're going to do. And this is very important. It's about knowing if there is or not carcinoma in situ, and this will have some implications if you want to go for radiochemotherapy. It's controversial, but some literature suggests that if you have carcinoma in situ, in particular if it's diffuse, you're going to have a worse outcome if you treat patients with radiochemotherapy. It allows you better histological evaluation than just doing a biopsy. I completely agree that it's not 100%, but it's important to know if you have an adenocarcinoma, pure squamous, urothelial, it's not perfect. You're not going to be right in some cases, but I mean, most of the patients will get a better histological evaluation if you do a full TURBT than if you just do a biopsy. And then the final one, which to my point of view is the most important one, is the question of debulking before radical therapy, that to my point of view is absolutely central. So Professor James said that the diagnostic tools have been largely unchanged in the past 30 years or even 100 years. I completely agree. The prognosis of patients with muscle-invasive bladder cancer has not improved enough in the past 30 years, which is also true. We have some delays in patients' management, and this is also true. We completely agree on that. But this is not a reason to remove the first therapeutic step. And maybe this is also a question of being a urologist or being an oncologist, but the TURBT is a therapeutic step, even in patients with muscle-invasive bladder cancer. So improving the treatment of patients with bladder cancer will take a combination of innovative diagnostic procedures and therapy. It's not a question of doing a TURBT or doing an MRI. So it's not an instead. I think it's a plus. It's a question of combining TURBT and MRI. And seeing MRI only as a tool to stage muscle invasive or non-muscle invasive is very reductive, because it also gives you a lot of information about multiplicity, size, appearance, location. It gives you information about potential nodal invasion, bone, and everything. So again, I use it in my practice. I find it very, very useful. And this VIRAT thing is reductive. I use it for a bunch of different, to get a bunch of different information. But I use it in combination, not instead. So I think here it's very important to separate two different clinical scenarios for localized bladder muscle-invasive cancer. You have the situation of patients for whom you're going to consider upfront trimodal therapy. And those ones that are going to have excellent results are the one with unique clinical T2 or very small T3, no CIS, which you will not know if you don't do a TURBT, no hydronephrosis, completely resected patients. So I do not see how you get a complete resection if you don't do a complete TURBT. The MRI is never going to remove the tumor. So this is a very important thing to consider patients for upfront TMT, and I'll show you some literature about that. The second situation is completely different. It's any T2, T4 patient that is going for neoadjuvant chemotherapy with 4 to 6 cycles, MVAC, GC, this is not the question. And those patients might be reassessed after neoadjuvant treatment. I agree it's not standard of care, but anyone who has been to a urology congress in the past 3 years knows that this is something we're considering more and more. And for those patients, we might want to consider local treatment based on response. But if you want to know about response, first you need a re-TURBT. But if you want a complete response, you need the biggest, the largest debulking that you can do. So in those two situations, in both situations, the TURBT is going to be central in patients' management. We know the variables that are associated with radiochemotherapy success, and amongst those variables, the fact that you have a complete TURBT is extremely important. It's one of the factors that has the highest association with disease-specific survival. There are some other factors such as hydronephrosis, stage, some literature about CIS, but the completeness of the TURBT is extremely important. And this is true if you want to treat the patient with radiochemotherapy, but this is true whatever local treatment is chosen. So you have the results of radiochemotherapy on the left and radical cystectomy on the right, and what you can see on the survival curves is the difference in survival for the patients who are complete responders and the patients that are not complete responders to the treatment. So either radiation plus chemotherapy or neoadjuvant chemotherapy plus radical cystectomy. And what is extremely clear is that complete responders have much better prognosis, and TURBT is the first step to complete response. The chance of getting a complete response is obviously going to be much higher if you debulk than if you don't. And I do not want to oversimplify here, but I like to compare the complete response rate after neoadjuvant chemotherapy between upper tract and muscle-invasive bladder cancer. So, there are a lot of analogies in the way we treat those patients. There are both urothelial carcinoma. I completely agree that there are some molecular differences and some differences in immune response, infiltration, and everything. But I mean, those tumors are close. When you look at the rate of complete response after neoadjuvant treatment in prospective trials in UTOC, the rate is always lower than 15%. While if you look at complete response in the neoadjuvant chemotherapy trials in bladder cancer, the complete response rate, for example, in VESPER, is around 40%. This cannot only be explained by the fact that those are two different tumors. And to my point of view, some part of the explanation here is also that in one case, you debulk the tumor with a TURBT, while in the case of upper tract, you don't. I mean, it's just a point of view. It's not proven, but I think that it does make sense. Then I'm going to look a little bit at the bladder path study. So obviously, Professor James knows it much better than I do, and it's an extremely nice study, and I really commend the whole team for doing it. But it's important to look in details at the results of MRI and radical cystectomy results for the patients. So those are the results from 2021, and then I will show you the results from 2025. So I did a small tables double entry for those patients that were considered to have possible muscle-invasive bladder cancer in the bladder path study. And we have a real life specificity concern. If you look at the patients that had a positive MRI, so the patients for whom the test said, well, the tumor is muscle-invasive, this is 14 patients. At the end, you had 5 patients that did not display muscle-invasive cancer. So the specificity was 65%, which is extremely low. And this was early analysis, but if you look at the analysis from the 2025 paper, well, it's more or less the same. You have 17 patients in the study that underwent multiparametric MRI and for whom it was diagnosed, they were diagnosed with muscle-invasive bladder cancer. And when you look at the patients that finally had a TURBT or cystectomy and were diagnosed with non-muscle invasive bladder cancer, the number is 6. So 6 out of those 17 patients that were considered to have muscle invasive bladder cancer based on the MRI finally had non-muscle invasive bladder cancer. That's a specificity of 70%. And it might even be lower because in the group of patients that were considered to be muscle invasive, some went directly to treatment and like radiochemotherapy, didn't get TURBT, didn't get cystectomy. So it is possible that some patients did get radiochemotherapy for a non-muscle invasive disease. So when you look in the details at the numbers, even though for the primary endpoint, the patients were treated quicker, which is, I completely agree with that, there will be a significant amount of patients that are going to get radical therapy for a muscle-invasive bladder cancer while they have a non-muscle invasive one. And well, this is true at initial diagnosis. We also use TURBT to restage patients with T1 tumor to be sure that they do not have T2 tumors. And in that setting, MRI is interesting. It predicts the patients that will have muscle-invasive tumor and re-TURBT. But this is assuming that re-TURBT is only performed to rule out muscle-invasive bladder cancer, which is not true because we do re-TURBT in T1 also to be sure that there is no residual tumor. So here again, MRI cannot be used alone. And same after neoadjuvant chemotherapy. After neoadjuvant chemotherapy, you have some association between MRI response and the true response. But again, the specificity is a concern and the imaging is not good enough. So my conclusion is going to be there. Do not choose, do both. So the TURBT alone is the nice Morgan car that probably Professor James might like. And the MRI alone is a little bit back to the future car. So if you want to get the super-car, to my point of view, you should be doing both.
Thank you very much, Alessandra. I think this was very, very well taken message. Well, pointed out, of course, what is the urological point of view. Professor James, I think that I want to take some comments from Alessandra. Probably you would have to convince more the radiation oncologist than the urologist to change the paradigm, because it's actually common message that we get from our radiation oncologists that TURBT is the foundation for the efficacy of trimodal therapy.
Yeah.
Just an example, if you have a patient with a 77 centimeter solitary bladder cancer, no hydronephrosis, no CIS, so that would be the, let's say, perfect candidate for trimodal therapy. Do you think that the results, I mean, I'm talking about the results of the Massachusetts General Hospitals, where this patient would receive probably 2-3 TURBTs and a neoadjuvant full chemotherapy before going to chemoradiation. Do you think that the results for this patient would be comparable if you just take a sample of the tumor and you give chemoradiation, just using chemo as a radiosensitizer?
Sure. Yeah, I mean, the interesting thing is that their results look very similar to ours, and they're doing a lot of surgery. We're doing much less surgery. And so I'm not at all convinced their results are any different to ours, even though they are insisting on this complete resection. We literally never send people back in to re-resect. And bladder preservation is much, much more widely done in the UK than it does in the United States. So 2/3 of muscle-invasive bladder cancer is managed, with UK style, because it's the UK, chemo RT. So we're doing some sort of TURBT because it's in the standard pathway, but we're not doing this insisting on complete debulking thing at all. Just to pick up on Alessandra's points about the inaccuracy of the MRI. I mean, we would agree with that, to be honest, I don't disagree with very much that you said, because most of the patients got an MRI and a TURBT before they went on to radical therapy. So specifically no patient had a cystectomy without having a TURBT first on the MRI arm. So we're not, but where we are skipping the TURBT is where we are very satisfied that there is, very clear extravesical tumor on the MRI scan, and the patient needs to get on with chemotherapy. So you're right, there is a grey area where we're uncertain, and mostly we're addressing that by doing TURBT as well. But the striking thing was that despite the fact we've done an extra procedure, patients are still getting to treatment much quicker, because you as the urologist know, having done the MRI scan, that you're dealing with a bad patient, and that that somebody senior like yourself, Alexandra, needs to be doing the procedure, and you need to get on with it. And so it's acting as a triage tool that allows you to tailor the patient's treatment more precisely. I completely agree that you can't we're not doing solely staging with MRI and not doing TURBTs. I think that would be wrong. I don't think we're actually disagreeing very much at all, to be honest. But I do disagree about the debulking. I do not think you need to debulk. That was largely a criteria made up by the Mass General team, because they were so worried urologists wouldn't send them patients that they fixed it so that they got good patients. So if you've got completely debulked patients with small tumors, you've got small T2s, you're going to get good outcomes, and you're going to show good outcomes back to your urologists. And exactly as per Alexandra's slides, if you treat patients who get complete responses with anything, you'll see better results than patients who don't respond well. That's universally true of all cancer care. It's not.
Thank you very much. I think that Professor Mariappan, we just moved to the the last lecture is actually the verdict from
absolutely.
Yeah,
we're waiting for the editor-in-chief of European Urology Oncology to give us the verdict of this debate.
Thank you so much. It was a pleasure to listen to both of you, and I have to say it's unfair to Nicolas to ask another French urologist to be, I would say, in the middle of that, and to do. It will not be a split decision, but it was a very balanced, I would say, debate. It was not very aggressive, and at the end of the day, I think that Professor Masson-Lecomte had a conclusion which was fair. So I would like to go back to certain principles. It's difficult. My main message is difficult to skip TURBT at the moment. I don't know who is listening to us. I assume that we have a majority of urologists online. And honestly, behind TURBT, there is a lot because, of course, most of the patients who are diagnosed with a bladder cancer, they undergo cystoscopy for hematuria, for symptoms, and so on. So I would say that the endoscopic step is difficult to skip. And if you do an endoscopic step, do it properly. So we are fighting a disease which is clearly not just a cavitary disease, especially at the step of muscle-invasive bladder cancer. There is the endocavitary phenomenon, and as urologists, I think that the message from Professor James is quite clear. We are fighting a systemic disease, but on top of that, should we do the debulking, or should we try to remove as much tumor as we can from the urinary tract? I think it makes sense as well also, because there is this bladder wall dissemination, and the systemic dissemination is unclear. We have circulating cells, we have node invasions, and of course, MRI may be accurate today to define the aggressiveness of the disease within the bladder wall, but we have another problem, which is the systemic dissemination to the nodes. And so far, in 2025, it's not accurate enough to use tape imaging or molecular imaging in the field of urothelial carcinoma. So the conjunction of what we have known in the field of prostate cancer, with the addition of molecular imaging to, I would say, regular imaging, such as MRI, has changed the face of the disease. It's not ready for prime time at the moment. The goal of TURB is not just to do a diagnosis, but at the step of non-muscle invasive bladder cancer is a curative intent, which means that we all know that when we do BCG instillation or mitomycin instillation, there is no chemoablation of the tumor. So the main step, which is crucial, is the quality of the TURBT. There is no reason why at the step of muscle-invasive bladder cancer, when it comes to T1 high grade up to T2, this is the borderline situation where I believe that the TURBT remains crucial. And I would agree with Professor James that in T3, T4 tumor, the role of the debulking is really unclear. But in the patient where I believe TMT is the most suitable and radical cystectomy as well, I mean the T2 and M0 patient, then the debulking has a role. We are even in an era where we are raising the question or avoiding cystectomy at the time of the patient having received a TURBT, complete TURBT plus neoadjuvant chemo. And so we are discussing how to enhance or to design such protocols at the moment. So it means that we believe that radical endoscopic surgery exists and it makes sense in certain patients that are suitable for a curative intent. So there is a role of TURBT, of course, and you can see also from the data that we have in the non-muscle invasive bladder cancer setting that there is upstaging also at the time of TURBT. It is true that if you have the MRI before the TURBT, it can make a great deal of difference because you can appreciate the aggressiveness of the disease. Most of the time, the patient are referred to the urologist, they have clots, they have endoscopy, then they undergo the TURBT, and then we raised the possibility to do a CT or an MRI. And it appears that after TURBT, it is less accurate. So it's also a question of organization, availability of the MRI, and waiting list, potential waiting list for the OR. I think it makes a lot of sense. And you can see that in the borderline cases patient, those who were not muscle-invasive bladder cancer, there are a certain amount of patients that are not doing very well following the EORTC nomogram. You look at the progression rates in T1 high grade, those were borderline. So let's go back to our topic of today, which is muscle-invasive bladder cancer. But please bear in mind that T1 high grade already, if we met the equivalence to what it is in the field of prostate cancer, should be considered at CT3B, Gleason 5+5, 12 positive biopsies out of 12 and PSA of 75. I think Ashish Kamal has made this parallel few months ago, and it is clearly interesting. So TURBT in MIBC, the picture is clear. Before three-modality treatment or before radical cystectomy. The current standard of care for MIBC is morbid. Whatever you are looking at, it is not an easy disease to go through, even if you want to survive. Each modality is associated with significant long-term toxicity. We need to de-intensify as much as we can. Be careful, there is a difference between clinical complete response and pathological complete response. And this is something which makes also a great deal of difference. On MRI, 34% of radiological complete response had residual disease at the time of radical cystectomy in a publication by Andrea Necchi in European Urology in 2020. 10% of residual tumor missed by experienced radiology using the VIRADS. So, of course, we are doing better. The accuracy is improving. We have a most homogeneous way to diagnose, but do not forget that those who are speaking tonight are probably experts of the field. And if you disseminate the use of the MRI in non-experts' hands, it can make a difference. On RETURB, you can see 60% of complete response on RETURB after chemo have a stage superior to T0. So I took your slide when you were speaking, and you said that those who had a biopsy, Nicolas, were doing as well as those who had a complete TURBT. But there are plenty of papers in the literature, if you look at those old papers with advocating maximal TURBT before RC, you can see that CTC, so circulating tumor cells, is not always clinically relevant, but they are already there during the preoperative stage. And it appears that we are in a moment in time where we see that ctDNA, circulating cells are more and more markers that we are investigating into the direction of diagnosing, I would say, micrometastatic phenomenon. And we probably would benefit from the addition of new markers to say whether or not in that situation we can skip the TURBT, in that situation we should stick to the TURBT. So complete TURBT appears in the vast majority of cases to be a truly important step. And you can see that maximal TURBT before neoadjuvant chemotherapy and delayed radical cystectomy in some patients. Look at the difference in terms of survival curves in this paper from PAC in UROWebinar, released in UROWebinar in 2020-21. So the difficulty today is to read between the lines, because if you are looking at finding arguments in the literature to support your vision of the situation, both Alexandra and both Nicolas did a great job. We all know that T0 is the best opportunity for cure the patient after radical cystectomy. But you can see at the curves, it doesn't mean that when you are T0 at the time of cystectomy, that you are cured from the disease. Look at the overall survival at 5 years after a T0 cystectomy. So the situation of maximal TURBT before TMT, we can see in the literature from the experience that we have in the field that the second TURBT improves disease-specific survival. But the question is, why not already from the first endoscopic procedure? So the question today is maybe to decrease the number of TURBT during the TMT, or to challenge the way we have been doing TMT for many, many years. But I don't know how we can skip it definitely, especially if you look at the data about watchful waiting after maximal TURBT and chemotherapy. You have the retain one single-arm phase 2 with MRI from Galsky, which was released in Nature Medicine. You have the HCRN GU16 257 single-arm phase 2 of non-inferiority, so you have recent paper. And the strategy to focus on active surveillance after neoadjuvant therapy, we have still there. It's a good question, probably, on a scientific perspective, very difficult to answer, because we have two critical challenges. Do we have the necessary tools to determine complete response accurately? And I believe that from this perspective, MRI should be an asset in the equation on the road to success. But it's not enough in 2025. And if we miss persistent disease, can we rescue these patients? And this is the only question. Otherwise, we will all agree. So if you want to determine complete response, you will rely on cytology, CT, cysto-TURBT. But maybe it's not enough. So look at all the trials that are in the pipeline at the moment. I was talking to you about the RETAIN trial. Most recent data were released at ASCO GU 2025. And you can see that, obviously, there are some unsolved questions that we should try to assess, or to try to find some answers thanks to this trial that are ongoing. Look at the design that we have in the RETAIN trial, for instance, TURBT, then dose-dense-MVAC, then the second TURBT, and then there is, I would say, the different groups where we can advocate active surveillance when there is no residual tumor. But in each of these trials, there is the addition of molecular pathway, biomarkers, and I would say a step further into the direction of what we do at the moment in terms of clinical diagnosis. The written trial, you have the 2-year metastasis-free survival for the intention to treat patients was 72.9%. And you can see that once again, we are trying to allocate the different subgroup according to the existence or to the positivity of the mutation or not. And I think it is going into the good direction when you look at the molecular precision that we are missing at the moment. So probably we are raising the good question, but we need to step into swim into personalized medicine also in the field of bladder cancer, to be fully in agreement with Professor James when it comes, for instance, to mutation-positive patient on active surveillance. Look, if you read between the lines, you see that the behavior of the tumor, the natural history of the disease, is far away from what we know in typical urothelial carcinoma, as mentioned by Professor Masson-Lecomte, and the different histological variants. We go further, we go deeper in the knowledge, in the understanding of the disease. Once again, so several design to explore the positivity and the use and the possibility to skip either radical surgery or some endoscopic procedure, but with the help and with the advent of probably new markers, and this is absolutely important. So what I want to emphasize, and that we have more and more effective neoadjuvant therapy, raises the stakes for bladder preservation. Of course, they are a game changer in the field of metastatic systemic treatments such as Pembro EV that will come soon to the stage of localized disease. And then we can add to what we use at the moment, UTDNA, MRI, as you see that I mentioned, and ctDNA. But MRI is not enough in 2025 at the moment to skip TURBT. And look at the potential use of ctDNA analysis in advanced urothelial carcinoma. So there is probably something that we will bring very early in the earlier phases of the natural history of the disease. So I believe that we should consider bladder preservation, but we are using criteria, clinical criteria in daily practice and radiological criteria that are not ready for prime time. And there is a need probably for the outcomes of this trial to let us know what is going to be the best group or the best subgroup of patients which would be suitable for skipping any type of surgery, including endoscopic or radical surgery. So outside the scientific rationale, we are in a webinar, we are teaching to the young generation, so we need to be open-minded, and I'm not saying that I will be doing TURBT in 20 years from now, but I'm still doing it in 2025. We should commit into clinical research, we should be open-minded, but there are medical legal issues outside the scientific rationale. And we need to skip and stick to the guidelines. We have good EAU guidelines, good ESTRO guidelines, and do not forget that we are discussing data that are under the umbrella of clinical research. And this is very important because we do not want to disseminate the wrong information. So what I would like to say is that in 15 years of practice, I became much more conservative in PCA, prostate cancer, but much more aggressive in high-risk non-muscle invasive bladder cancer and T2 MIBC. TURBT for the moment, in my mind, is here to stay, and it decreases the volume of the tumor. It is not true that it is important in every case. I agree fully with Nicolas James. MRI can certainly help us as an accurate additional tool in the pre-treatment workup strategy, but not at the moment to replace TURBT, which is a full step of the treatment. This is what I wanted to share. So I would have changed the title because it's TURBT and imaging. There is no way we can skip the use of MRI today, and we should use it properly and wisely.
Thank you very much, Professor Hupré. It has been an extremely interesting debate. Unfortunately, we are running out of time, and we only have 1 minute left. If I may just try to give the final message. TURBT in the context of muscle-invasive bladder cancer is here to stay, as Professor Hupré said. Please note that we have not only the European guidelines, but the NCCN 2025 guidelines that clearly state that TURBT and re-TURBT is the foundation for bladder-sparing treatment and trimodal therapy. At the same time, and Alexandra made it very, very clear what are also the point of strength, but at the same time, I think as a urologist, we need to consider with interest what is the proposal of Professor James, because for too much long time, the urologist has just considered TURBT as a simple sampling procedure, sometimes transforming an asymptomatic non-bleeding patient in a bleeding patient and without really adding a lot. So I think that the message is that in selected cases, as it was pointed out by our debaters, probably an MRI combined with the flexible cystoscopy and the biopsy in a bulky tumor in an elderly patients, I would say not only a matter of just speeding up the process, but probably to give to the patient the best tailored treatment, which is a less invasive treatment. Once we know that probably we can deliver what is a kind of palliative treatment certainly in a less invasive way. So I think this has been a debate where really we can get some a lot of take-home messages. And I would like to thank you, all of you, also on behalf of Professor Mariappan, who co-chaired the session. Thank you very much for the debater and to our audience. And we apologize if we could not really, for the sake of time, address all the questions. Thank you. Bye-bye.
Thank you very much.
Bye everyone. Bye-bye. Bye-bye. Bye-bye.